This is another difficult question to answer even by my ENT colleague. 35-year-old with quinsy, was it there? But there is an argument against it. Even one single episode of quinsy also is an indication for tonsillectomy. One episode also. But we do interval tonsillectomy. Interval tonsillectomy. I think maybe if the examiner is not very meanly thinking that now is it quinsy or history of quinsy? Obstructive. For that the ENT surgeon's answer is obstructive sleep apnea is a indication for surgery for adenoidectomy, but it is not among the indication of surgery in case of tonsillectomy. Adenoidectomy के लिए obstruction, respiratory obstruction become a criteria, not for the tonsils, is the logic of a ENT surgeon. Yes, grade 3 tonsillitis is there, but the mere grade 3 tonsillitis, the mere presence of tonsillitis is not sufficient to do surgery. It is the frequency of episodes is definitely the criteria. So, even if it is grade 3, if it is the first episode or only one episode, that won't stand as an indication for tonsillectomy. And we have to listen to ENT surgeons because for them the bread and butter is tonsil only, no? It is tonsil breakfast, tonsil lunch, tonsil dinner. So they are the authority. So I think by that consideration, quinsy, provided that the examiner doesn't have interval tonsillectomy in the mind, becomes the answer. I hope so. I don't know. This is a straight repeat question of the recent AIIMS November paper which we have discussed about cochlear implant. Then acute epiglottitis, thumb sign. You all agree with me? Perichondritis is pseudomonas. Action potentials in the cochlear cells basically come from the inner hair cells which are connected with the cochlear nerve, not from the outer hair cells or from the hair bundles or tunnels of Carti. Oval window opens into scala vestibuli, and danazole leads to hirsutism, acne and vaginal dryness. You all agree with me? Then highest rate of production. Was it the question? Everything is high in its own style. What is the meaning of highest then? You can't compare LH values with HCG values, right? Maybe examiner's interest is base level say kitna times rate of rise. It once more depends on which trimester we are talking also. Am I right? So I think provisional answer can be HCG. Anybody disagree with me? That was one more question, no. No, one more question is there. Highest carbohydrate containing. Examiner is very hormonal this time in gynops. All is on physiology of pregnancy and hormones. He don't want you to know breech is done how, face is done how. So he don't want you to go to labor room also. Reading room making he wanted to decide whether you have studied about the hormones well or not. Emergency contraceptive does not lead to interruption of pregnancy. If it interrupts, it is no more called contraceptive at all. That is the logic. Sniff test is for the bacterial vaginosis. I think you all agree with me. In menopausal flushing, we don't use tibolone. Tibolone is mainly used as a hormone replacement therapy which has effect only on the bones. It has nothing to do with the selective estrogen receptor modulators are very much used. Some of them precipitate hot flushing. Tibolone is used only for bone. It has no role in hot flushes, but anyway, we'll come back on that. But SCRMs some SCRMs precipitate flushing, but some are used to treat flushing. Both ways it is right. Central venous pressure is a DM gynecology question. How many answered it as decreased or increased? Okay, I'll give you absolute values to solve the problem. Basically, if you take CVP, normal people it is 9 millimeters, 9 centimeters of water. That becomes 7, become 4, become 3.8 by the time it is final trimester of pregnancy. That is the reason in pre-eclampsia and eclampsia patients and those who have a congestive heart failure in pregnancy, we can't depend on the CHF, on the CVP to manage the fluid replacement, because it is markedly decreased is what we need to basically remember. Okay, doctor, I think this question moved you out of your comfort zone, right? But we can't help it because this is the cremation session. Suddenly you discovered in the middle of burning that you have some debts with that guy who is burning. So this is that kind of question. By ELISA, when do you be able to detect? It is generally 2 days before the next expected day of period. So that falls around 28th day of the cycle where ELISA can be able to detect. Atonic PPH prophylaxis, what will you not do? We do controlled contraction prophylaxis definitely. Any uterotonic agent after the delivery of the anterior shoulder is also prophylactic. But after the delivery giving oxytocin is no more prophylaxis. Am I right? IM, IV or intrathecal after delivery? Was it shoulder delivery or the baby's delivery? What was given? Delivery of the baby only, probably. But after delivery of the baby, there is no role to be called it as prophylactic. You all agree? Okay, what is your other potential answer otherwise? We'll debate on that. You mean carboprost is not given? Carboprost is very much given, recommended drug. We give 250 micrograms of IM or intramyometrially. Huh? We give it as a treatment? No. With the delivery of the shoulder we give, no? We give ergometrin also, unless contraindications are there. So I think oxytocin would have been the answer. I am not sure. Don't dishearten if you answered something else. For fetal RH isoimmunization cord blood, the levels of the fetal anemia was given, not RH, you are very sure. Then sinusoidal pattern. NST sinusoidal pattern is the option here. Okay. And then that becomes the answer. Now at ovulation, female gamete is basically secondary oocyte. Primary oocyte is at the time of the birth.